I'm Rashmi Halker Singh. It's my pleasure today to be joined by Dr. Jessica Ailani. He's one of the authors of a recent publication, position statement from the American Headache Society, routine migraine standard as a standard of care for women's health. Welcome, Dr. Ailani. I'm so happy to be speaking with you about this very important topic.
Well, thank you so much for having me. Really, we're honored that you chose to highlight this article.
So first of all, why now? Why is now the moment that AHS should be endorsing migraine screening for women?
There's a lot of pieces that have been happening in the background that this is something I feel like the society's been really interested and invested in for a while. But the moment came when our government was actually looking into the fact of making some changes to the women's health visit. And that's a crucial moment that we knew if we didn't get this statement out in time, we were going to miss this moment that we've been thinking about for a long time. The women's health visit is an annual visit where a woman goes through a number of different screening processes. It can be done at gynecology or primary care, or sometimes both. I feel like personally, I've had a women's health visit twice every year, one with each type of doctor. And in the visit, they screen for many things. Are you at the age that you need a colonoscopy? Have you had a DEXA scan if you're that age? What's going on with the mammograms? What is your general health? And then cardiovascular risks, social risk determinants of health. It's a huge list of items. And how do you make it onto that visit really becomes a background of how that visit will get paid for. And so to become an important item on the visit, you have to actually have some push and pull from a political standpoint, that it has to be deemed as an important standard of care, and that it kind of makes it on that Medicare annual visit screening protocol. And then that kind of follows through with the rest of the insurance companies. So as this legislation is really moving through government, we wanted to make sure we had a statement about how important migraine is. And it's really a big women's health condition. And that because it's underdiagnosed and often completely not diagnosed in a clinical practice, that screening should be done for all women, especially those that have had their menstrual cycle. So we're talking about starting screening as young as potentially 9 or 10 in some young girls who considered women if they've had their cycle already, and then continuing that screening every year so that if migraine does start later in life, you're going to be able to pick that up. So that really was the impetus behind this position statement and moving it forward at this time.
I think that's so important. You speak to this a little bit. You've already spoken about this point a little bit about the stakes, right? Like how much migraine impacts women. How often it's missed. We often say that migraine is the leading cause of years lived with disability amongst women. Can you share with anyone who's viewing a little bit more about that? What is the impact of migraine on a woman's life, if you will? And why is it so important that we identify this and catch it early?
Right. So the lifetime cumulative incidence of migraine amongst women is about 43%. So that's a really high number. And why is it important we make the diagnosis? Without a diagnosis, many women are going along with this disease and they're not getting appropriate treatments. They're either relying heavily on over-the-counter medications, which is just fine if they need it every once in a while and the treatment works. But we know from epidemiology studies, we know from impact studies, we know from different studies we've looked at, start and stop of treatments itself, that unfortunately a large portion of women with migraine, while they receive a diagnosis, might not receive acute treatment, might not find the acute treatment they are using to be effective. This then leads to chronification of the disease. They go from having 2 to 3 attacks a month to 6 to 8 attacks a month to 12 to 16 attacks. And, they're pushing into that chronic migraine. Being a woman itself is a risk factor for chronic migraines. This is a reason we really want to pay attention to this group and think about those times and opportunities we have to make that diagnosis and do so early. Making a diagnosis doesn't mean you necessarily have to change a treatment the patient is using. You just want to assess if that treatment is effective and effective for all attacks, or are there times that they're using the emergency room or urgent care? Are there times they're missing work or social obligations or school because of an attack? And should we start to consider prevention in these patients? And do we want to make a referral if the primary care or the OB-GYN is not comfortable managing the disease, but to further evaluate and treat itself?
Yeah, absolutely. I mean, I've been seeing patients all day long. So many of my women patients have shared with me that their migraine attacks began around the time of puberty. And when I listen to the impact that this has had on their quality of life, it resonates. And if we can catch it early and be proactive about it, it can have such an impact on quality of life and really their life trajectory, if you will, too.
Absolutely.
One of the things you point out, your co-authors point out, is the screening tool that we're hoping that these women's health specialists use in their clinical practice, right? It's the ID migraine tool. When I think about our colleagues in women's health, they have so many different screens that they have to do. It's not just migraine. They have to think about, as you mentioned, their mammograms, their other health risks that they have to manage as well. What about our colleagues in women's health? What is this tool that we want them to implement? How challenging is it? What does that look like for them?
So it's actually super, super easy. We didn't make this recommendation without really carefully considering the idea that we're adding a burden to all clinicians. It's not something we really want to do, except we think the outcomes would be really huge and beneficial to society and to the patients. This screening tool called ID Migraine, first, I want to say we recommend you can use any screening tool you like. ID Migraine is really fast and quick and easy to use in clinical practice. And it's just 3 questions. And you don't even have to ask them. You can get a paper copy and have the patient fill it out before they come in to see you. If you've got that great electronic medical record system that pre-ask questions for you, it can become part of the pre-ask questions on an annual basis. And you're just picking up if the patient's having headaches that cause disability, if during a headache they feel nauseous or they don't want to eat, and if during a headache they feel like lights are more bothersome than not. And if they're answering yes to 2 out of 3, the screening is positive. It means there's a very good chance this person has migraine. When you see them then in clinic, you can ask further questions to really, confirm that this is migraine, not a secondary issue. And there are other tools you can use to help you with that, like green flags and red flags. Is this a headache type the patient has had most of their life? Does it run in the family? Do the symptoms meet criteria for migraine? These are more green flags. Red flags are symptoms or signs that are abnormal, like their neurological exam is normal. They're having new onset headaches after the age of 50. They have a history of cancer or an autoimmune disease, and this is a new type of headache. And it's a lengthy list. Now, if you're not comfortable going through all that and you don't want to do that during the screening visit, you've got 2 options. You bring them back for a routine follow-up visit if you're primary care and kind of go through that process to confirm the diagnosis, or you refer them to see a neurologist to really confirm the diagnosis and start treatment options. And there are other things you can assess during that visit too, like, hey, you screened positive, you might have migraine. Do you ever feel like these attacks are impacting your life? And should we really take that next step? I think just asking those questions, first of all, oftentimes we'll hear from our women patients that they've felt unheard for a long time, that they've been having these symptoms, mentioning it, and it kind of gets pushed off. And so just opening dialogue can be really impactful for patients and really start that journey of treatment. The second thing is, in this patient population, even if it's not disabling now, the fact that you're asking about it might make them think over it over the next year. And when it does start to impact their life, if it does, they're going to bring it up again and know it's a safe place to talk about this, even if that means you're going to refer them elsewhere. At least they know where to start that conversation.
I think that's such great advice. Listening is impactful. It can be therapeutic, builds trust with the patient as well. And really, ID migraine is just 3 simple questions that opens that conversation as well. So, any final things you want to share with anyone who's watching?
So, I hope you take a quick look at this article. It's not very difficult to read. I think it really will teach you a little bit about how to identify migraine and why it's so important that we screen all of our women patients at least once a year for this disorder. I'm excited we were able to get this done. It was a great group of authors who really thought through why treating migraine early as that first menstrual cycle can really change the trajectory of somebody's life. And I think that's really why we all got into medicine, right? We want to change people's lives. And this is a very simple way to make that change happen.
Thank you so much for your hard work on this as well as everything you do. I really appreciate it.
No problem. Thank you so much.